Good evening, everyone. I'm Dr. Crystal Reese. I am an obstetrician and gynecologist. I currently work at Jackson Hospital, Jackson Clinic, OB-GYN clinic, and thank you very much for having me tonight. So I actually wanted to introduce a couple concepts because as an OB-GYN, I hear a lot of misconceptions when women come into the clinic. Number one, and this is going to be interactive, so please shout out answers, whatever you're thinking. What age group needs to see an obstetrician and gynecologist?
What age group you think we'll start with? Maybe 14?
14, okay. Anybody
I
else?
was gonna say 16.
16, okay. All right, well,
And I just said 14 because of the growth and the maturity level of the girls today.
okay. Yeah. So I actually don't put an age group on anyone. I don't say that at this certain age you need to come and see us. At this one you need to stop. I think we're women doctors, so at any age that if you're a really young child, if your mom thinks you need to come and see us, or your dad thinks you need to come and see us, come and see us. I see as young a patient as I'm trying to think, 8 years old for some vulvar conditions. So on the outside of the vagina is the vulva. And then I see women in their 80s and their 90s for different reasons. So now there is an age group there is a certain age that we expect women to initiate having their pap smears or their pelvic exams. And does anybody know that age? Just throw out a number. 20, 40, somewhere in between.
About 18.
18. We actually start doing pap smears at age 21. So very close. 20 years old. And the reason, it seemed like in the past everybody thought that they were getting a pap smear very young, 18 years old, and maybe they were in the distant past, but nowadays we start screening at age 21 because we expect women younger than that to have abnormal pap smears. And so we don't want to be doing over-testing of those women because typically when we're checking for paps, we're checking for cervical cancer. So we're screening for that. So we're expecting to see women younger than 21 to have abnormal pap smears, and we also expect them to have subsequently normal pap smears after that. So that's why we don't start screening until age 21. Does anyone know how often you're supposed to have a pap smear?
Yearly?
Yearly. Okay. Yearly. So I say yes, come and see us once a year. But we've actually changed our guidelines regarding pap smears, and there's actually a difference between a pap smear and a pelvic exam. So a lot of women think that when we're doing a pelvic exam that we're automatically doing a pap smear, and a pap smear is a specific test. It's screening for cervical cancer. So we might be doing a pelvic exam just to make sure everything looks okay. If you're complaining of an abnormal discharge, we're checking for that. But the screening for cervical exams, as long as everything was good with your last pap smear, we actually can spread it out as much as 3 years, as much as 5 years. Now, there are a few gynecologists that might screen a little bit more often than that because they don't feel comfortable stretching it out. But what we find is that cervical cancer is a really slow-growing cancer. So even if we were to stretch out that screening 3 years, 5 years, that we're likely to catch those women that might be developed. So, but that does not mean that you stop going to see your gynecologist, okay? All right, other things for other age groups. So, gynecologists, OBs, of course, we're baby doctors, so we deliver babies. We take care of women throughout their pregnancies. And gynecologists, we can deal with a lot of other different things. So we deal with abnormal bleeding, we deal with infertility problems, we deal with contraception, pelvic pain, pretty much anything that concerns women, we can see you for that. And if it's outside of our scope of practice, we'll refer you to the appropriate people. So there's actually a statistic that says that about 50% of women only see their gynecologist for their care. They don't see their primary care physician, they just go and see their gynecologist, and their gynecologist, they expect them to be able to manage pretty much everything. So I say, go see somebody. Go see your gynecologist, go see your primary care. Another misconception I hear is a lot of women, I'll see a lot older women who come in and they haven't seen their gynecologist in maybe like 15 years. So, like I said, I see older women in their 80s and their 90s, but at what age do y'all think that you stop seeing your gynecologist?
I wouldn't think you
Good answer.
Yeah. What she said.
You don't.
You don't.
You don't.
Since she brought that up, I won't wait till you finish to ask this question.
Sure.
When I had my head from my gynecologist, told me that I no longer had to come and see him. I could go to my primary doctor.
Okay. So this is the thing. I don't know very many primary care physicians, especially nowadays, that actually look at a woman completely, you know?
Right.
And it's not that your vagina ceases to exist once you have your uterus out. There's still other areas that need to be examined and checked because you're not going to be able to evaluate on the inside of your vagina. That's what you have your doctor for. So as long as somebody's checking, I'm not saying that the gynecologist is the only person that can check, because there are other doctors who feel comfortable checking, but a lot of people don't feel comfortable. Even doctors don't feel comfortable. They're like, oh no, you need to go see a gynecologist for that, because it's a sensitive area.
Even though they are medical doctors, they would not, or they prefer not to examine. Back in the day, you know, your physician did everything.
Everything. And now we're so subspecialized that I get consulted to see patients sometimes in the hospital because they're having their period. So, you know, it happens. What else do we handle that, you know? Oh, so I think there's also the misconception as you get older that things just happen, right? So maybe you leak a little bit of urine, you might leak a little stool, and this is just normal things that happen as you get older. And so I just want to clear that up. It's not. You do not have to suffer. You can have a doctor who cares about, you know, that this is affecting your personal life, your ability to socialize. So you can definitely come and see us for that too, and we'll help you get on your path. And I'm trying to think, I actually have a whole list of things that I wanted to mention. Okay, we covered that. So we kind of already talked about after hysterectomy, abnormal bleeding, heavy periods. So I wanted to touch on heavy periods and bleeding because I feel like this is kind of a silent problem that a lot of women suffer from, like really heavy periods and menstrual cramps, and they just kind of deal with it because it's something that, you know, women have to deal with. You know, it's like, it's our lot in life. But that's totally inaccurate. Nowadays, there's so many medications, there's so many treatments that you can get that will help you live your life to the fullest.
So when you said there are treatments, like what? Because I myself, you know, I don't have to worry with that anymore, but back then I was one of the ones that suffered with cramps. I have a very low tolerance for pain, first of all. And the heavy bleeding and clots and, you know, you name it, cramping. I couldn't even go to school. I would miss school for like 2 days in so much pain. So
Not necessary.
what my doctor or my gynecologist did, they put me on birth control, which it did at the time when I was at a young age, and it cut down on the heavy bleeding and everything. But as I got older, it seemed like it didn't do any good anymore. But I still stayed on. He still kept me on, but that was it. You know, pop Motrin, Aleve, you know, but nothing that could, and the pain was still there.
Okay. So yes, that's typically our go-to. So non-steroidal anti-inflammatories, A lot of women can be controlled very well on that. And then usually we go in a stepwise fashion. So hormonal therapy. So we're talking about birth control, whether it's oral, whether it's the patch, whether it's the insert into the arm, insert into the uterus. And all of these can help with bleeding and help with cramping. But it doesn't work for everyone. So that's when you start, yes ma'am. That's when you start going more stepwise, right? So things like for heavy bleeding, you can do a simple procedure like endometrial ablation, which is burning the lining of the uterus. It doesn't necessarily address pain though. So if you have double symptoms going on, you have to kind of either address them separately or do a one attack procedure, something like maybe like a hysterectomy or something like a uterine artery embolization, which is not in my field, but I do recommend that a lot because it's a non-invasive procedure that is, you can be in and out the same day. So they essentially block the blood supply to the uterus. And it can help with bleeding and pain and decreasing the size of fibroids if you have that.
Yeah.
You spoke earlier concerning birth control and different types of birth control, but yet the birth control now is like it's the side effects and what it does. So whereas it may alleviate one thing, but yet it's a possibility that it's causing something else. So what's the?
So the side effects that I talk mostly about, because all of the combined oral contraceptives, so when I talk about that, it's the contraceptives that have both the estrogen component and a progestin component. Those ones typically can lead to things like possible weight gain, nausea, headache. If you're a smoker and over a certain age, then it can lead to things like blood clots. But there's other forms too that are just progestin only. So those ones we recommend in women who have maybe a lot of other medical issues. And so those side effects are a little bit less. But yes, like you said, there's side effects with everything, but a lot of times it helps out a lot more than harming. So, and we appropriately evaluate all of our patients to make sure that they are actually good candidates for whatever treatment that we offer them. And if it's contraindicated, we don't offer it.
What is hardening?
What is what?
You said hardening. Is that a word you just used? Did you hear?
Pardon?
Having? Maybe
Having?
you said having.
Maybe. Sorry.
No.
I'm from Alabama. Yes, ma'am.
Okay, so I've been told that it's normal not to have a period every month, but, okay, so if it's not every month, so when does it become unnormal, whatever is not abnormal, excuse me, when does it become abnormal?
So I would have to disagree in a way. So if you're not having a period every month because a doctor is making you not have a period every month, because there's forms of birth control that can do that, right? Then that's okay, because we can make you have a period every 3 months, we can make you not have a period, then that's okay. But if you're on by yourself not having a period every month, I would probably say you need to be evaluated, because there's things like polycystic ovarian syndrome that will cause you to have that. There's other elevations and other hormones that can affect your period. The period is like a vital sign. There's heart rate, there's blood pressure, there's your respiration rate, your temperature. All those are important, but your period is almost like another vital sign. And based on that, we can kind of make determinations about what's going on with your well-being.
Okay, my next question is, with birth control, how long, because I got off birth control like a long time ago, and usually, I don't know, how long do you usually take for it to get out of your system? That's one question, and then I'll let you answer that, and I'll ask my next one.
Yeah, so it depends on the birth control. So Depo, we say give it up to a year, because it could, yeah. But everything else pretty immediate, because obviously people can get pregnant like that if they miss a dose of their oral contraceptive or whatever other hormone they're on. Mirena, maybe not so much. I mean, women can still get pregnant on that, but the likelihood is very low, just because it's secreting a hormone on the local uterine environment. And I'm trying to think if there's anything else else where it takes a little bit longer. No, that's pretty much the only one.
Okay, well, that's the main one then, okay. But my last question would be, with that being said, how is what is the most, not healthiest, but recommendation wise, whenever you're talking to people, what is the best birth control type to use?
That's a personal decision.
Okay,
So the most efficacious, is the next one on, is the implant that's in the arm. So you have the least likelihood of getting pregnant with that one. Probably because we place it and then you can feel it in your arm and it's not gonna make its way out typically. So anything where you let the user take control of their birth control, you're probably gonna have a higher failure rate. So that's your pills, that's your ring inserts, those are your patches. Because you have to remember to change them out, take them. And then the next one would be like the intrauterine device. So again, we place the next one on that goes in the arm, the Mirena, or the Paragard, Skylet, all of these IUDs that go in the uterus and they stay there. So.
Yeah, my question was, when you stated earlier about, as far as having your cycle, you go 3 months, like every quarter. Is that good? Is that good for a female body to?
Yes, the other misconception is that you need to have a period. Oh goodness. So you do not need to have a period to cleanse yourself. You do not. It's fine, as long as we're making it happen. It's by prescription, doctor's prescription, but other than that. So the whole reason why women have a period is because essentially your body has prepared your uterine lining to be receptive for a pregnancy. So, biologically, that's the purpose of it. Because when you don't get pregnant, then your uterine lining sheds itself, and then the process starts all over again. So as natural as it is not to be pregnant every month or every 40 weeks, it's natural not to get your period.
How old do you have to be before you start having mammograms?
So this is kind of a source of contention between providers because different groups have different recommendations. But the group that I actually ascribe to, the American College of Obstetricians and Gynecologists, we say at age 40. However, if you have a positive family history of breast cancer, then you should start screening 10 years before. So if your mother, your sister got breast cancer at age something really young, let's say like 35, then you should be starting even younger. And that's the same thing as colonoscopies as well. So colonoscopies start at age 50. And actually there's recommendations that in the African American population that they start at age 45. But if you have a family member that has had it, colon cancer, then you need to start much younger. And that should all be covered. Yes, sir.
Is there ever an age where you cannot get pregnant?
Say yes,
Yes, there is. So if you haven't started menstruating yet, you are unable to get pregnant. Technically, you could ovulate before having your first period and get pregnant, but that would be very abnormal. And then after you undergo menopause. So that's different for every woman. The average age is 51. So as you know about averages, there's women who undergo menopause much earlier and there are women that undergo menopause much later. So those are the ages. Groups.
And
Yes,
so,
ma'am.
do you lose your period when you get menopause then?
Yes. So we consider menopause. Menopause is the lack of a period for 12 months. So something really important that I don't think a lot of women know is that if you go 12 months without having a period, and then all of a sudden, say 15 months in, you have a period, then that's what we consider postmenopausal bleeding. And that is something that actually needs to be evaluated by a doctor. You don't ever undergo menopause and then start having your period again and that be normal, because it can actually be a sign of cancer or a polyp or precancerous changes.
So, I guess, so losing your period would be the sign that you are going through menopause?
It
Or how do you
depends.
know when you're going through menopause?
So if you're of the appropriate age, so sometimes I see women around age 44 coming in saying they're having hot flushes, that their periods have become irregular. And so the change is not immediate. So you can go several months without having a period, and have those symptoms and then have one, and then go several months again. But that still you still need to be evaluated, just like when you're young and you're going 3 months without having a period or 2 months without having a period, you still need to be evaluated, because that could also be a sign of that something else is going on. So
what are the symptoms of, is it perimenopausal, like before actually going through menopause? What are the signs that you are going through that?
So very similar to actually menopause itself. So hot flushes, you might experience some vaginal dryness, some skin changes, some hair changes, night sweats, insomnia, mood changes, depression.
My sweat slang.
Okay, so this is bad news. 10 point, I think it's 10.7 years.
That's how long menopause lasts?
That's
is that
how
average?
long the hot flushes can last on average. That, and you know what averages mean, right? So some women a lot less, and some women a lot more. And I've definitely seen women who have suffered for 20 some years, and it's just like unfortunate, but it happens. And that can also be influenced by your diet as well. So
Your diet?
like a high sugar diet.
You're saying 10, but years ago, I mean, that number has not always been 10, has it? As far as you know, because I was told 7 years. I was told 7.
So 7 years you can have, before you undergo menopause, you can have those hot flushes, but the changes usually, I'm saying on 10.7 years, you can have the hot flushes. So, unfortunately.
What is the purpose of menopause?
Well, there's some unique theories behind that.
Where you said
Well, I guess if you think about it, it's almost like the end of your, there's some unique theories. There's a grandmother theory, so that you undergo it, so that your children, that you can be around to take care of your children's children, but it's just natural. It's a natural change of
But
life.
it's not the end of like you having sex though, right? It's
No.
just, okay.
Although, sexual desire dysfunction can arise during menopause because you undergo all those changes. So mood changes, vaginal dryness, hot flushes. You don't want to be touched at night. You're sleeping in another room.
That's a change.
But I always say, if you don't use it, you will lose it. So, all vaginal dryness can be helped by having sex. So if
Don't
you
sin, y'all. Don't sin.
it can be helped by
What you saying though?
It can be helped by having sex. So if you are experiencing any vaginal dryness or any issues with the tissue down below, if you're having bleeding afterwards, if you have sex more often, it will be improved. And then if it doesn't, like if you can't get initiated because of the vaginal dryness, then you can start off with lubricants. If that doesn't help, then move on to like a vaginal estrogen, or there's several things that can help it. Vaginal
I know that some people experience cramps and things of that nature before the cycle, but is there such thing as like headaches and things like that before the cycle? And is that a sign of going through menopause or anything like that, if that was not the case beforehand?
So headaches and migraines are normal when you're having your period for some women. So if it's changed in quality or onset, that might be something you need to talk about with your physician, just because it depends on when they're coming on, like if they're a morning headache, if you're having any nausea associated with it. I would be thinking of other things, especially if it's new onset. But perimenopause, hormones are doing completely different things, so if all of that's ruled out, then you could attribute it to just being kind of like hormonal imbalance, unfortunately. All right. Okay, so I brought a lot of information, and I know women talk a lot, so ideally, if you know somebody that might be affected by anything, or you know somebody who's looking for some type of information regarding anything reproductive related, come up, ask me, grab some information, and we'll go from there. Yeah. I'm trying to make sure I covered everything on my list. Y'all asked some excellent questions that I didn't even have to.
Can I ask you a question?
Yes, ma'am.
My youngest daughter, she said had a hysterectomy done Friday,
Okay.
and they took her uterus out, but they left the ovaries.
The ovaries.
Because they said the ovaries is gonna keep her from going into early menopause.
Absolutely.
How does it, I understand.
So the ovaries are actually the part of our bodies that produce all of our hormones, almost all of them. So when we do hysterectomy, even if it's an older lady, nowadays I still recommend, unless the ovaries, something looks abnormal about them, I say keep them in because they serve a purpose, even if it's minuscule. So ovaries protect you from heart disease. They protect you from going through things like stroke. So if you notice that when women undergo menopause, usually they are at a higher risk of having those things happen afterwards. But it's called the estrogen effect. So we keep them in, we take the uterus, we might even take the fallopian tubes because they serve no hormonal purpose, but we'll leave the ovaries behind because they're still doing their job.
So the cycle comes from the uterus and not from the ovaries.
They work in conjunction, but the bleeding itself comes from the uterus.
Okay, so there won't be no more bleeding when they get the uterus.
Correct.
Okay.
Correct. Unless never mind. Getting really technical.
Just a quick question, are you accepting new patients?
Yes, ma'am.
And where are you located?
So I'm located at Jackson Hospital, Jackson Clinic, the OB-GYN clinic. But yes, I love new patients. Alright. Oh, I think I had one other point here, but everything else was asked. Did we talk about at what age we stopped doing pap smears?
We did, no, you didn't.
You didn't finish it. You
Sorry.
asked. You said begin, but never got to the end.
Okay, so we talk about that?
Yeah.
So, does anybody know?
I say you should stop and.
Okay. So pelvic exams, we should not stop.
Versus pap.
I would recommend that happens, every couple of years at least. That somebody looks down below, looks at the skin on the outside. If you're having any issues on this side, do an internal exam. But pap smears, so screening for cervical cancer, we typically stop at age 65. Unless you have a history of abnormal pap smears. So if you have a history of a high-grade pap smear, then typically we do it for 30 years after that last abnormal one. So that means if you have one age 65. Yeah. But that doesn't mean that we would be doing it annually because of those guidelines. It kind of stretches it out either to every 3 to 5 years. So, okay. All right. Well, thank y'all for such excellent questions. And if you have any questions that you don't want to ask in front of everybody else, come up.
Let's get out there. Raise a hand.